everybody, this is Wael ElKilany, Professor of Cardiology at Shams University. Today we are going to talk about the pharmacological treatment of heart failure. Our heart is a very hard-working. It's like a donkey. It's a hard-working organ. It starts working from 3 months antenatal till the end of life. So you sleep and your heart does not sleep. What's the function of the heart? The heart acts as a pump that gets blood from behind and throws it to the front. Let's take an example of the right side of the heart. It gets blood from the venous system, throws it to the lungs. And the left side of the heart, it takes blood from the lungs and throws it to the systemic circulation. And this is, of course, a continuous process. The definition of heart failure, it's a complex clinical syndrome of impaired myocardial performance and progressive activation of neuroendocrine system leading to circulatory insufficiency and congestion. So what if the heart fails and you want it to work better? We need to understand basic concepts about the kinetics of the myocardium and the circulation to understand how do we treat heart failure. First concept is the concept of preload. It is the initial stretching of the myocardial cells prior to contraction. It works according to a law known as Frank-Starling law. This means the ability of the heart to change its force of contraction and therefore stroke volume in response to changes in the venous return and, of course, to a limit. So let's try to make it more simple. As the right atrial pressure increases, the cardiac output increases. And this is the steep part of the curve. It's the green part of the curve. And then the curve flattens. It's the red part of the curve. When the curve flattens, this means that the right atrial pressure increases without actual increase in the cardiac output. This is the preload. Let's talk about the afterload. The afterload is the load that the heart must eject blood against. It's like pushing something uphill. So of course it's more difficult. And this is the situation for the heart. If the heart is the donkey, so sometimes the job is very difficult for him to do. Let's make it somewhat more funny. So in this picture, we can think of the preload and the afterload and the contractility. So these are the three factors that control the myocardial function. It's the preload and the afterload and contractility. So what we do by treatment is that we try to decrease the preload, decrease the afterload, and improve contractility. Let's see the treatment. What happens during ventricular failure? During ventricular failure, blood pressure decreases. So there is increase in the sympathetic activation, direct myocardial toxicity, increased heart rate, vasoconstriction. And from the other side, there is also increase in the RAS activation, which means increased salt and water retention and interstitial fibrosis. And there is also neurohormonal activation. These are the three basic effects that happen due to left ventricular failure. So what we do by treatment, we try to block the sympathetic system by the beta blocker, to block the RAS activation by the RAS inhibitors, and of course the aldosterone antagonist, and the neurohormonal activation by the ARNI. What about prevention versus treatment? Do we start early or wait for the patient to be symptomatic? Simple rules to delay the overt heart failure. So number one, to prevent or delay the development of overt heart failure in a patient with impaired ejection fraction, but without symptoms. We should treat hypertension, treat with statins, hyperlipidemia, stop smoking, of course, obesity, dysglycemia. We should treat all these risk factors. Some treatments with diabetes are proven to improve the onset of heart failure and prolonged life. ACE inhibitors in a patient with asymptomatic left ventricular dysfunction is actually recommended with class 1A or B. So using ACE inhibitors in asymptomatic left ventricular dysfunction or stable coronary artery disease is recommended. Beta blockers also in asymptomatic left ventricular dysfunction is also important. What about symptomatic patients? First of all, diuretics is extremely important in treatment of symptomatic heart failure with reduced ejection fraction. Diuretics are important to improve symptoms and exercise tolerance and decrease the risk of heart failure hospitalization. But there is no effect on mortality. So we can use furosemide with the initial dose 20 to 40 milligrams, and the usual daily dose is 40 to 240, and we can reach up to 500. Torsemide, starting dose 5 to 10 milligrams, and we can, the usual dose is 10 to 20, and we can give it up to 200 milligrams. Potassium-sparing diuretics like spironolactone or eplerenone, the dose of spironolactone is up to 100 and eplerenone is up to 50 milligrams. So, first of all, we start by diuretics for all patients for symptom relief or for relief of congestion. And of course, diuretics work by decreasing preload. Next is ACE inhibitor, beta blocker. ACE inhibitor, beta blocker. And if the patient is still symptomatic after giving ACE inhibitor and beta blocker, you start an MR antagonist or mineralocorticoid receptor antagonist. This is the second step. Why do we use these drugs and why are they on the top of the list? Because these three drugs, beta blockers, ACE inhibitors, and MRA antagonists decrease mortality. So they are all given class 1A as we can see here. Let's take a look at the dosing. The ACE inhibitor, captopril for example, you can start with a very small dose like 6.25 milligrams 3 times daily. And of course, captopril is given 3 times daily because it's a short-acting ACE inhibitor. And you get to the target dose of 50 milligrams 3 times daily. So you start by a small dose and you up-titrate the dose gradually till you reach the target dose. And you always try to reach the target dose as long as the patient does not have symptomatic hypotension. So it's not important to get hypotension by numbers, but the most important is to get symptomatic hypotension. This is what makes you decrease the dose or stop upgrading the dose. Second is enalapril, 2.5 milligrams twice daily, and take care that enalapril should be given twice daily. Lisinopril, ramipril, trandolapril, these are given once daily. So captopril 3 times daily, enalapril 2 times daily, and the rest is once daily. What about the beta blockers? The beta blockers, there are 4 beta blockers that are proven to improve mortality in heart failure. Bisoprolol, you start by 1.25 and you end up to the target dose of 10 milligrams. Carvedilol, 3.125 twice, and take care here, carvedilol should be given twice in heart failure, and up to 25 milligrams twice. Metoprolol, and you start by 12.5 to 25, and then you go to the target dose of 200 milligrams once daily. Nibivilol, you start by 1.25 and you end up by giving 10 milligrams at the target dose. So in the beta blockers, you take care that carvedilol is given twice daily. What about the ARBs? The ARBs, the candesartan, you start by 4 to 8 and your target dose is 32, valsartan 40, and take care here twice daily. Also, valsartan is giving twice daily, while the target dose is 160 milligrams twice daily. So it's 320 milligrams. Losartan, you start by 50 and you give the dose to the target dose up to 150. And of course, the MRAs or the mineralocorticoid receptor antagonist, the eplerenone is up to 50 and the spironolactone is also up to 50. So these are the doses. And there is a simple, very important rule about the beta blockers, that the beta blockers, you should start with a very small dose and up-titrate very gradually. So, bisoprolol, carvedilol, metoprolol, nibivilol, there is a rule that says start low and go slow. So you start with a very small dose and you up-titrate the dose very slowly. Okay. Let's see what's next. So, first of all, we give diuretics to all patients, and then we give ACE inhibitors, beta blockers, and MRA antagonists if the patient is still symptomatic. What if the patient is still symptomatic after all these drugs? So you check if he is in sinus rhythm and the heart rate is above 70, so you give ivabradine. And if the patient is able to tolerate ACE inhibitor or ARB, so you can give ARNI. And we are going to talk a bit about this. The ARNI is a molecule that contains sacubitril valsartan together. It's a single molecule that contains both molecules. So sacubitril valsartan is known. It inhibits the AT1 receptors and it acts at the same action like any RAS inhibitor. But sacubitril acts differently. It inhibits the naprolysin. The naprolysin is an enzyme that deactivates the AMP, BMP, and CMP. These are vasoactive peptides resulting in vasodilatation, decreasing blood pressure, decreasing sympathetic tone, decreasing aldosterone level, fibrosis, hypertrophy. And of course, it's a natriuretic. So inhibiting the naprolysin, the enzyme that deactivates the BMP, this means that the BMP levels will elevate and this will improve the function. So it acts by a dual mechanism. It acts as valsartan and added action by inhibiting the naprolysin. And the dose here is the sacubitril valsartan. You start by 50 twice and your target dose is 200 twice. And the ivabradine, it decreases the heart rate. It's an IF channel blocker. It decreases the heart rate from 5 milligrams BID to 7.5 milligrams BID, and this is the maximum dose that we can use. The angiotensin receptor neprilysin inhibitor, which is the ARNI, decreases risk of heart failure, hospitalization, and death. So it is important for mortality. Here, this is the fourth drug that improves mortality. As we said before, ACE inhibitors or RAS blockers, beta blockers, MRA antagonists, and this is the fourth one that improves mortality. It is the ARNI, or the angiotensin receptor neprilysin inhibitor. The IF channel blocker, or the ivabradine, decreases the risk of heart failure, rehospitalization, and cardiovascular death, and this is the fifth one, in symptomatic patients if the ejection fraction is less than 35, in sinus rhythm and the heart rate is above 70, but the patient should be on maximum tolerated doses of the previous medications, of course. So we started by diuretics, and then we started ACE inhibitors, beta blockers, patient still symptomatic, MRA antagonist, patient is in sinus rhythm, still symptomatic, and heart rate is above 70, ivabradine. If he can tolerate the ACE or ARBs, you can shift to ARNI, as we said. What if the patient is still symptomatic, although all this treatment? So you can give digoxin, you can give nitrates, and you can give some other drugs. Let's see, hydralazine and nitrates. Do we use it that frequent? Actually, no. But it is important to use in two cases. If the patient is on maximum tolerated doses of the above medications and still the patient is still symptomatic, or the patient is contraindicated to have an ACE or ARBs, and this is the most important indication for these groups of drugs in heart failure, patients with renal impairment. So you cannot use an ACE inhibitor or an MRA, so you use hydralazine nitrates, and of course it's giving a lower class. It's 2A for patient symptomatic or maximum treatment, and 2B if the patient is contraindicated for other treatments. What about digoxin? The gold standard in the past. Now it's having a class 2B, so it's not that important. Digoxin is used in symptomatic patients, sinus rhythm, or in atrial fibrillation, of course, on top of an ACE inhibitor, beta blockers to reduce hospitalization, yes, but no improvement of mortality. So digoxin does not improve mortality. Digoxin improved hospitalization. What about the omega-3? Some say it's important. There are few trials and it's giving class 2B only. There are some treatments that are actually totally contraindicated that you should not ever use during heart failure. This is the glitazones. These are drugs for diabetes, non-steroidal anti-inflammatory drugs, diltiazem, verapamil, and the combination of ARBs, ACE inhibitor, ARBs with ACE inhibitors with MRA. So this triple combination is contraindicated. So you use an ACE MRA or ARB MRA, so but never ACE ARB. Okay? So this combination is forbidden. Finally, let's summarize. The patient starts with diuretics, and then you give ACE inhibitors, beta blockers. If still symptomatic, you give MRA antagonist. And then if still symptomatic and the patient's sinus rhythm, heart rate is above 70, you give ivabradine. If the patient is still symptomatic and he can tolerate ACE or ARBs, you can give ARNI. And then if the patient is still having resistant symptoms, although all these the previous symptoms, you should consider giving digoxin, nitrates, hydralazine, or omega-3. And finally, the heart, if you give all these medications in a good way and you know how to tailor your treatment for your patient, I think the donkey will be able to go uphill and do the job. Thank you.